Hello everybody, and happy Valentine's Day from Phoenix, Arizona today at Phoenix Children's Hospital. Very appropriately, I am here to talk about congenital heart disease and its developmental approach. So thank you for letting me share some of the things that I know about something I'm very passionate about. So to begin, just some brief information about congenital heart disease. What is it? Congenital heart disease, or CHD, occurs approximately 1 in 100 births, or approximately 40,000 babies per year. 25% of babies with CHD will have a critical defect. 97% of babies born with a non-critical defect are expected to survive to 12 months, and 95% of those to 18 years. For babies with the critical defect, 75% are expected to survive to 12 months and 69% to 18 years. Not only is it my work and my work passion, it's impacted me personally. I have a nephew who has tetralogy of Fallot. 2 colleagues have children with hypoplastic left heart and tetralogy of Fallot, and a good friend of mine has a baby with a coarctation and a VSD. So I feel like it finds me sometimes. So to begin, let's just talk briefly about what a normal heart looks like, and we'll also talk about circulation. So when you think about a normal heart, there is red blood and blue blood. Red blood has the oxygen, blue blood does not. What you'll see in a lot of these defects is mixing of blood. So you'll see blue blood where red blood should be, and red blood where blue blood should be, and sometimes a lot of purple, a lot of mixing of blood. So let's talk briefly about what normal circulation looks like. So if you look back to the picture, if you have a picture in front of you, there are 4 chambers in the heart. The right and left atrium on the top, and the right and left ventricle on the bottom. There are also 4 valves called the tricuspid, the pulmonary, the mitral, and the aortic valve. So for circulation, the left atrium on the top picks up the oxygenated or red blood from the lungs. It passes through the mitral valve to the left ventricle. The left ventricle is your main pumping chamber. The red blood then goes through the aortic valve, to the aorta, to the arterial system, where it gets pumped out to the rest of the body. So after delivering all that red blood to the body, the deoxygenated or blue blood enters the venous system to get carried back to the heart. Blood from the lower body will enter the heart through the inferior vena cava. Blood from the upper body enters the heart via the superior vena cava. The blood then enters the right atrium, passes through the tricuspid valve to the right ventricle. It is then pumped through the pulmonary artery to the lungs. There it releases all the CO2, picks up oxygen again, carried back to the left atrium via the pulmonary veins, and the process begins all over again. So it sounds really complicated, but it happens every day in all of us to keep us all healthy and alive. There are tons and tons of cardiac defects, so I'm just going to go over just a couple to give you some basic information and some basic knowledge. They're typically broken up into 2 categories, the acyanotic and the cyanotic. The acyanotic defects, you'll see overall no change in their O2 sats. These babies should be satting, 95 and above typically. And these babies look really healthy. If you look at them, you wouldn't necessarily see that they had a heart defect. You wouldn't see anything that looked off. Examples of these will include an ASD, VSD, AVSD, PDA, and these all result in increased blood flow to the lungs. Others include pulmonary valve stenosis, aortic valve stenosis, and coarctation of the aorta, and these result in obstruction of blood flow. So I'm going to go over one of each in the acyanotic and cyanotic categories. I picked a VSD because it's the most common type of defect. It's probably the one you'll see most often. And if you think back to normal heart, and I said, remember, red stays with red and blue stays with blue, this is a primary example of red going into where the blue blood should go. So a VSD is just a hole in the wall or septum that separates the left and right ventricle at the bottom of the heart. This allows the red blood to flow into the right ventricle. So instead of, oxygen-rich blood then gets pumped to the lungs instead of the body. So some smaller VSDs may close on their own. Others will require surgery, either via patch closure or stitch closure. So The cyanotic defects. These babies look a little more sick. They look a little more blue. They have lower oxygen saturations. Typically, you'll see these babies with SATs of around 75 to 85%. That's an acceptable range for them. So where you'll see their bluish undertones, you'll see it in their fingers, their toes, their nail beds, especially their lips. I know of a little one, she's about 2 now, and her lips kind of always look like she's wearing that vamp lip color. And you may see it around their eyes too. You'll see just kind of this kind of dusky undertone. Some of the cyanotic defects include tetralogy of Fallot, transposition of the great arteries, truncus arteriosus, pulmonary atresia, total anomalous pulmonary venous return, and hypoplastic left heart syndrome. I'm going to talk about hypoplastic left heart syndrome as it's one of the most serious defects. And again, thinking back to normal, where red should be with red and blue should be with blue, you can kind of look at this diagram, and if you notice the left ventricle titled LV on the diagram, it is quite small compared to the right ventricle. They should be pretty similar in size. And if you look at all the purple that's happening, what is labeled PA is your pulmonary artery. This goes to your lungs. That should be blue. Well, what you see as labeled AO is your aorta. That is what carries the blood to your body, and that should be red. And it should be a little more robust looking, thicker. This one is kind of skinny and fragile looking. So you can see all their left-sided structures are underdeveloped. Without surgery, these babies will die within a few weeks. And surgery is done in 3 stages for these children. So usually the first surgery occurs within the first 2 weeks of life, the next is around the 4 to 6 month mark, and then the third occurs between roughly 18 months and 3 years of age. I have to add too, even with all of these surgeries, after that third surgery, which is called the Fontan procedure, these kids aren't quote unquote cured. It doesn't mean that they won't need a transplant at some point. These surgeries are all palliative to give them the best life that they can. It's not necessarily a cure-all. So how does CHD impact development? We all know it does, and it starts in utero. It starts before anybody lays a hand on these poor sweet babies. So for example, in hypoplastic left heart, there's a decline in the rate of brain growth in the last month of gestation. So these term babies have the brain of a 35 to 36 week preemie. If you work in the NICU, you think 35 to 36 weeks isn't so bad, and it's not terrible. We call that, late preterm or very late preterm. But these babies are term, and they already have kind of the cards stacked against them, so to speak. There's reduced brain blood flow in utero. There's a decrease in myelination. So the oligodendrocytes are the ones that are most sensitive to the low oxygen, and this can limit white matter volume growth. The volume growth gets slowed in that third trimester, and that's when the myelination is supposed to be occurring. And that's also the time where you start to get kind of those folds in your brain that trap all of the information for learning. And there's reduced connectivity in CHD. Their brains are just more sensitive to that because they're hypoxic before they even come out, sadly. And I just wanted to add a little about ECMO here. Up to 22% of babies and children who have to go on ECMO will have some kind of neurocomplication. With VA ECMO, there's a high risk of a right hemisphere injury. And if you work with older kids of the neuro population or adults, you know that those right hemisphere injuries is what we call the walkie-talkie patient. They don't really look like they have any deficits until you start really engaging with them. But how do you identify a walkie-talkie right hemisphere injury in a newborn? And I think sometimes you'll see these deficits start to be more noticeable as they get older, as they go to school. So where do the risks come from? Besides in utero, they come from surgery. So there's the circulatory arrest time, the bypass time, surgeon experience, and the center experience. The length of stay. Research has shown that stays greater than 2 weeks can increase the risk of developmental delay. I will tell you that almost every single one of our infants is in the hospital for a minimum of 2 weeks, and often much, much longer. So before they're 1 month old, they're already at a risk for developmental delay. And then there are all the complications that come with surgery and hospital stays. There's reintubation, prolonged intubations, delayed sternal closure. So sometimes our babies will return from the OR with their chest still open. Therefore, they have to be very heavily sedated, and that comes with a whole other set of issues. Necrotizing enterocolitis will delay feeding and create all kinds of other feeding issues kind of down the road. There's wound infection, there's line infections. Some of our babies have chronic kind of high oxygen needs, so that might limit them from being able to feed safely. ECMO has a whole set of risks. Seizures can be prevalent in this population. Chylothorax presents a whole set of feeding issues as well. We'll talk more about that a little later. And then just feeding intolerance. If a baby doesn't feel good, they're not going to want to eat. So some of the risks that can occur in surgery. Cardiopulmonary bypass. So that's just the heart-lung machine that replaces the function of the heart and lungs during surgery. So it does all of the work and supports the body while the heart is being repaired. Things you might see in an operative note that you would want to pay attention to is cross-clamp time. So that is the time that they use to stop and empty the heart. You'll see circulatory arrest. This is when the perfusionist turns off the pump, drains all of the patient's circulating blood into a reservoir. The patient is then cooled to 18 degrees Celsius. So at this point, there is no blood circulating. It is also called deep hypothermic circulatory arrest. And I made these little charts just to show you what is considered short, medium, and long for cross-clamp time and cardiopulmonary bypass time. It's important to know if you see a time that is, greater than 151 minutes, you know that baby might be at a higher risk to have some neurological issues. And then also in regards to cooling, the cooler you go, those are the times that kind of correspond with how long they can be that cool. And there's definite concern for neurological issues with cooling and being that cool for that long. I got this information when I went to a conference last summer, and it was so interesting to see that anesthesiologists were really concerned with neurological outcomes. Prolonged stays, that we know that that's going to increase their risk for developmental delay. And these kids are going to have longer and multiple hospital stays, usually within their first 5 or so years of life. And as therapists, we know that's when the bulk of your learning happens. That's how you learn how to learn. Your language, your motor skills, everything is developing in that first 3 to 5 years of life. One study found that Davies et al. Found in their study that the most prevalent procedures that result in long-term hospitalization include trach vents, the need for organ transplants, which is many of our children, completed transplants, also many of our children, and VADs. A VAD is a ventricular assistive device, usually used as a bridge to transplant. So we had one patient that fit basically all of this criteria. So these babies or children are sitting in the hospital for long periods of time, not getting the normal interactions they need to develop. Most parents aren't able to be at the bedside 24/7. So that's where we come in as therapists to help and hopefully help them, reach their maximum potential. So developmental care in the ICU. It's not always easy to execute in an ICU because clearly the #1 goal is keeping everybody alive and stable. But questions to ask yourself daily is how is what I'm doing with this baby right now helping their brain development? And sometimes it might just be holding them to calm them. That is okay. What is developmental care? It's neuroprotective. It promotes autonomic stability. If that baby is not stable, does not have stable vitals, they are not going to be able to do anything else that we would like them to do as therapists. It emphasizes the need of the infant and family, and it strives to minimize all of the negative effects of the hospital experience. Necessary, but negative. I found some information about medical trauma and stress, and I thought this was a good place to share it. Now medical stress is a term that is similar to like a PTSD, but in a response to what has happened to either patient, the child, or sometimes to the family, the parents, the siblings. But some of the things that can cause medical trauma stress is maternal separation. Our babies are taken from their moms very frequently, immediately. There's the life-threatening illness. There's pain and stress. These babies, their pain threshold gets maxed out so quickly. There's isolation. Typically when your baby is born, it goes right onto mama's chest, and now they are in an isolette. They might be intubated. They're not allowed to eat. And there's sleep deprivation, or there's over-sedation. So they just can't interact with their environment at all. And one day in the ICU can include up to 20 quote-unquote painful procedures or interactions. So our goal is to make sure we are not one of that 20. We know that there are very many necessary things that need to happen, but an interaction with a therapist or a nurse or a child life specialist hopefully is not one of those. And surgery, again, we know these are all the necessary evils that keep the baby alive in the ICU. So responses to medical trauma or stress can include re-experiencing the event, avoidance, hyperarousal, or a negative mood. It can be in response to one single event or multiple events. And it doesn't necessarily have to be a really negative event. It just might be something that baby or child perceived as negative, or just the 10th negative thing that happened to them that day. Most of the studies regarding this are on pediatric patients and burn patients. Burn patients don't get fully healed, but they definitely get better. And cancer patients may go into remission, but CHD is lifelong. It's not something that ever really goes away. And this was from Dr. Sood, and she had some information about reported traumatic stress rates of CHD parents. My gut tells me that parents may have underreported, because only 39% of mothers with a prenatal diagnosis felt stress. My guess is that it's much, much higher, that they might not have been able to process it then. 32% of mothers and 20% of fathers felt stress at the time of hospital DC. And ironically, that number went up to 37% of parents feeling stress about 1 year post-diagnosis. And the question I put out to myself, to the parents around me, like, how does that stress affect how you parent? How does it affect how you parent the patient? And how does it affect how you parent potential siblings? I've not walked in those shoes, so I can't imagine what that is like. So at Phoenix Children's Hospital, we developed, it is called our Developmental Pyramid, and it was based off of something that two nurses did at Alfred DuPont Nemours, to involve the caregivers in the care. I know this is a little hard to read, but the top of the pyramid is the highest level of acuity. So there's not a lot that parents can do with the baby at that point, but there are things they can do for the baby. So you can keep me company, be in my room, decorate my room, definitely participate in rounds, ask questions. Like, this is your time to start to learn. You know, bring in some items from home, and you know, if this is ask my nurse if you can touch me, and how can you touch me? Where can I be touched? And then we have a thing called a journey board. It's kind of your road to discharge. So start getting familiar with that. The next level is a little further down. So the blue level says read my favorite books, sing or play songs. At this point, I might be ready for some therapies. And then bring in comfort items from home, talk to me and make eye contact. And at Phoenix Children's, we have a Beads of Courage program. So every day or procedure or therapy, a child gets a bead and you can string it along. And then, you know, the onus is on the parents to kind of keep up with those things. And then purple, you're getting more stable. Hopefully by now you should be extubated, possibly feeding. So help with daily care, so do diaper changes, do the temp, maybe some bath time, encourage play, however play is appropriate for that baby. Be holding, sometimes you can hold in the blue depending on where the baby is at, but be holding, be interacting, and participate in therapies. The bottom, the green part, is getting closer to discharge, so participate in cares more and more, help develop routines. but now the parents should be what we call nesting, so that they should be doing probably 90% of the care and kind of guiding the nurse, saying, you know, oh, I need these medications now, it's time for feeding, let's do this together. And by now they can start practicing all the things that they learn in their therapy sessions. So this is how we evolved our pyramid from this group, from Christine Martinenza and Jamie Klug. They developed a care partnership pyramid, and some of our nurses went to a conference and took some of their information and made it our own. So it provides the guidelines for the families, what they can do. It gives them things to be working on. So it can be really simple as putting on socks, or maybe putting on a headband if that baby can't wear clothes yet, but they can wear a headband. Or it can be involved as changing a trach, doing some deep suction, getting their kid out of bed by themselves and doing some walking. So like I said, each area is color-coded to identify the level of acuity and some of the things that they're encouraged to do. So like I said, the top level of the pyramid is highest acuity, and the bottom allows for the most direct interaction. The pyramid is fluid, so where the patient falls may change day to day. Some days it's hour to hour. So it is discussed with our team in rounds. The nurse will say, this is where they're at today, and review that with the parents so that they can say, okay, well, if they're green, like I need to be holding, I need to be doing these things. So environmental modifications, what can we all do? Reduce noise. ICUs are kind of noisy places. There's always a monitor or something going off. It can be hectic at times. So adjust your voices. Instead of yelling down the hall to your colleague, walk towards them. We had an issue in our unit by some very well-intended nurses about white noise machines, and they were ending up near the baby's head, meaning inches from their head. And one thing that I did is I put a decibel meter on my phone, because me walking in and saying that's too loud isn't very meaningful. But if I showed them the decibel meter, and it was very simple, saying like green, yellow, and red, and saying, look, like if I put this phone next to the decibel meter, kind of in between next to the sound machine, if I put the phone in between the sound machine and the baby, and it is reading red, that was really valuable to them, saying, oh my goodness, that's too loud, let's move it. And I was very pleased to see when I walked into a baby's room today that the sound machine was a good at least 3 feet away from the crib. And respond to monitors quickly. We are not nurses, so we can't necessarily be turning off monitors, but you can say to a nurse, like, hey, I know you probably can't hear it, but this IV has been beeping for 3-4 minutes now. Can I hit pause knowing that you're going to come in and respond to it? Bright lights. So we have the direct exam lights right over the baby's bed. Sometimes the doctors don't always turn them off after a procedure. So it's everybody's job to make sure that those don't get left on unnecessarily. Try to use natural light as much as possible, because that's what they're going to go home to. I have found that a lot of our parents like to keep their babies on the other end of the spectrum in the complete dark, so it's a cave in there. So it's important to do some education about light cycling, so help to promote wake time and sleep time, and knowing that they need that deep sleep for recovery and growth. One thing we can all do is just offer to help. If a nurse has to place an NG tube or bathe the baby or has to poke a baby for a test or something, offer to be that second pair of hands. That can help that baby maintain stability. Or sometimes there's just that really, really irritable baby who won't settle. The nurse has tried everything that she can, and she still has, hours worth of charting to do. Offer to hold the baby. You're helping the staff and you're helping the baby. So it's a really good way to make friends with your staff. And then in regards to developmental issues beyond infancy, these are some things that parents have reported. So a lot of their kids have difficulty with multi-step problems. Memory is a big issue. Difficulty with math tasks. Homework takes an inordinately long time to complete. Reduced attention. My 11-year-old nephew these kind of all apply to him. It's a struggle for him. Some of them will play with children who are a bit younger than they are, because they might relate to them more on an emotional level. they can't always do the things that typical kids can do. And you might see this as they get older. For some reason, they might not be able to learn to drive when they hit 15, 16. They might not be able to play certain contact sports for their own safety. Sometimes if they're a little emotionally behind, they might not start dating when their peers are starting to do those things. And then academic transitions can be hard. We spend the first few years in school learning to read. And then when you get to, fourth grade or so, you're starting to read to learn, and you have to do things with that information that you're reading. And you have to learn how to plan and how to organize. And that's sometimes where you'll see some of these kids really start to struggle. And then executive function, this is where a lot of our heart kids have difficulty. The good news about that is that there is an entire collaborative dedicated to neurodevelopment in CHD. It is called CNOC. CNOC stands for Cardiac Neurodevelopmental Outcome Collaborative. They have continuing ed, they have meetings. I was able to go last year and it was outstanding. And their current focus is on executive function. So for those of you who don't know, even though we're all therapists, and I'm assuming most of us are familiar with executive function, it is a set of behaviors responsible for purposeful, goal-directed activity. It's used to organize and direct cognitive activity, emotional responses, and overt behavior. So it includes things like inhibitory control, working memory, and cognitive flexibility. And these are the things that you'll see as kids kind of hit that 11, 12, 13 age. Okay, so I wanted to talk a little bit about feeding and swallowing in babies with CHD. Dysphagia in general is associated with poorer outcomes post-operatively. It can lead to delayed return to oral intake. It can lead to a longer hospital stay and increased costs. So talking to your team, you can tell them that you could potentially reduce cost and reduce stay if the earlier you get involved when it's appropriate. And this was a fact that I found kind of outstanding, that in 2007, Kogan et al. Found that the risk of intubation greater than 7 days increases the risk of dysphagia, and the number of days intubated directly affects the risk of not eating orally at the time of discharge. So in neonates, each day intubated increases the risk of not eating orally by the time of discharge by 10%. So that risk goes up by 10% every day. And I will tell you, a lot of our babies are very easily intubated more than 7 days. Some of the babies don't get a chance to eat at all preoperatively. A lit review by Golbus et al. Revealed 48.1% of patients with hypoplastic left heart had feeding and swallowing abnormalities, including laryngeal nerve dysfunction, glottic gap due to weakness, sometimes prolonged intubation, and GERD. 48% of them had a quote-unquote abnormal MBS, with 24.2% of them aspirating. So if you're walking into the room of a patient with hypoplastic left heart, you need to know that their risk for swallowing issues and feeding issues is pretty high, nearly 50%. And kind of in general with all babies with CHD, feeding is a marathon. Their body and their circulation pattern is often just not set up for them to be able to do it well. The cardiac output isn't sufficient enough to meet the metabolic demands of the body, especially the demands required for feeding. So what you're going to see in these babies is poor endurance, suboptimal intake. They don't have the energy to complete a full volume of their feed. Weak suck, but more so as the baby fatigues. They just can't maintain that good, strong suck for a long period of time. You'll see a lot of shorter sucking bursts. Again, they just can't maintain successive sucking, swallowing patterns. Sometimes these babies will get sweaty with feedings, and you'll definitely see poor weight gain. It is just really, really challenging for them. And GI considerations. They have reduced blood flow everywhere, and that includes their digestive system. So there can be an increased risk of necrotizing enterocolitis with these babies. If these babies get neck, they are usually made NPO for sometimes 5 days, 10 days, sometimes more, depending on the severity. Using breast milk, either mom's milk or donor's milk, can help reduce that risk. There's complications with delayed gastric emptying or hypomotility of the GI tract. If your stomach doesn't empty by the time that next feeding is due, why would you want to eat again? So you don't. And if the liver is enlarged, the stomach can become compressed, and then they're not going to eat well. They may not tolerate their feeds well. So you may see some emesis, general intolerance and discomfort, a lack of hunger cues, reflux behaviors, failure to thrive, and malnourishment. So their belly has to feel good for them to want to participate in feeding. Respiratory considerations. If you can't breathe, you can't do anything, and that definitely includes eating. So there's a decreased delivery of the O2-rich or red blood to the body. So it's just working hard to compensate to just be there in bed or in mom or dad's arms. And now we're asking them to essentially do a workout by eating, and it is really challenging for them. Sometimes they're just breathing too rapidly to coordinate that suck, swallow, breathe, and if they can't coordinate that, there's an increased aspiration risk. So what you'll see in these babies with some respiratory issues is tachypnea, so high, fast respiratory rate, increased work of breath, poor suck, swallow, breathe coordination, sometimes desaturations, and air hunger. Other complications that may impact feeding include chylothorax. Chylothorax is a buildup of lymphatic fluid on the chest wall. So these babies will have a really, really hard time breathing, and they'll have chest tubes to drain that fluid. So this results in a change to a low-fat formula so that this fluid won't build up again. So some examples of the formula are Empaport or Lipistart. There's one called Monogen. You can defat express breast milk. It just takes a little more work, a few more steps, but if moms are willing to do that, it's definitely an option. These babies will most often need to be on this modified low-fat diet for about 6 weeks. The challenge is if you have a baby who is a little bit older, 4, 5, 6 months or older, they kind of have established tastes, and they know what they like and they know what they don't like. And I have not seen very many babies like any one of these low-fat formulas. Even the defatted breast milk, you can see that the babies recognize a change. I can only envision it's like going from whole milk to skim milk for them, but it's likely a better option than the formula if it's at all possible. The concern is if the babies are on the formula and they don't like it and they won't eat it, we get concerned that they can lose their feeding skills if they're refusing. So sometimes in this case, I will offer something like small amounts of Pedialyte or small amounts of water, just so we can maintain skills. Neurological insults, we know that all of those can impact feeding depending on where the lesion is. Did they have a stroke? Did they have a brain bleed? Did they have seizures? We don't know. Was there a hypoxic event? ECMO comes with a whole set of swallowing issues very frequently, and any comorbidities. So DeGeorge syndrome, cleft palate, trisomy 21, even things as simple as tongue ties. Because to clip a tongue tie will cause a baby to cry, and if they have a shunt, they could cry and clot that shunt and potentially code, we don't clip tongue ties on our unit. So if I see a baby with one of those, I will most frequently tell the parent the likelihood of this getting revised while you're in the hospital is really, really quite low. So we have to kind of work our way around that when we have to. Prolonged intubation or multiple intubations, that results in reduced laryngeal closure and reduced sensation, so that can increase your aspiration risk. And pulmonary hypertension, aspiration events can have a significant impact on this population, so it needs to be managed a little more aggressively. So complications with vocal cord paralysis. This population is more prone to some vocal cord paralysis. Surgeries that impact the recurrent laryngeal nerve, or RLN, are the surgeries that involve any type of correction around the aortic arch and the Norwood procedure. And Sometimes PDA ligations can create some recurrent laryngeal nerve issues. The recurrent laryngeal nerve is a branch of the vagus nerve. Going back to grad school, it is cranial nerve 10. The left recurrent laryngeal nerve is longer than the right, and the left course is just under the aortic arch. So that is why we experience some swallowing difficulties. It controls all the intrinsic laryngeal muscles other than the cricothyroid. Up to 45% of patients with unilateral vocal cord paralysis, or UVCP, will demonstrate abnormalities on MBS, according to a study by Pham et al. In 2014. So that's nearly half. So one of the first things I do if I know a baby has had a surgery that can place them at increased risk is I will try to kind of wait and see if I can get that baby to cry before I do anything in terms of laying hands on them. Or ask the parents, how does their voice sound compared to before surgery? Does it sound different? Does it sound the same? And it can lead to longer stays. If that baby is unable to protect their airway for swallowing, they might need a feeding tube of some sort. So the feeding evaluation, these are the things that you want to know or you need to look at as you're going into a room and experiencing a patient. How are they being fed currently? Are they feeding orally? Are they feeding via ND or NG? Are they on a bolus? Are they doing continuous feeds? Are they not getting anything into their gut yet? Are they only on IV nutrition? Do they show hunger cues? If I walk in and that baby is looking hungry, I know like half my job is done. Are they getting formula? Are they getting breast milk? I try to note all vitals as I'm walking in before I lay a hand on that baby. How do they change with what I'm going to do? And what can I do to make them maybe not change so much? Note the baby's state before, during, and after your evaluation. Observe how they can move through the stages of being, sleep to wake and then back to sleep. Can they move through those stages? What supports help them get to that alert state? What supports don't help them? And it's important to be in contact with your nurse for kind of the after. I'll ask a nurse maybe an hour later, how did that baby do after I left? She might tell me that baby was really cranky, they were breathing hard, they needed to go on oxygen, they needed a PRN med. Then I know something wasn't working, and what can I do to change so it is better the next time? Observe for stress cues. I know many of you work with infants, so you understand stress cues, so I'm not going to go over them in detail. But that's how the babies communicate with us. That's how they tell us, I like what we're doing, or I don't like what we're doing. Clearly conduct your standard oral motor exam. Observe for tongue and lip tie. Feeding attempt. I always start slow. I will tell you that the Dr. Brown's Preemie is my go-to probably 90% of the time. I tell parents and staff that I'd rather see that baby work a little bit harder sucking than risk aspiration with them having to manage a flow rate that's too fast. Feeding is fluid, both literally and figuratively. It's constantly changing. What's safe and organized 1 minute can change the very next, and aspiration events in this population can be more detrimental. So goal setting. Before I talk about goal setting, I want to talk a little bit briefly about burping. Be mindful of the baby's incision. Sometimes it will be on the back, especially for babies who sometimes will have a co-arch repair and it will be on their back. So just be mindful to avoid that area. Babies can be on a chest, help to mom's chest or dad's chest for burping as long as they are comfortable. Now, in regards to goal setting, looking at the patient's projected course, how is that going to impact their feeding abilities? So we've had babies who have had to stay that entire roughly 4-month period between surgery 1 and surgery 2. So based on the fact that I know that this kid might be here for several months at a time, how am I going to set my short and long-term goals? And it changes. We know that goals aren't set in stone. For my goal setting, I always talk about quality over quantity. Parents and some staff will focus heavily on volume because if I ask the parent what their goal is, almost every single time that parent says, get that NG out, which I completely understand. But I tell them early on, if we focus on the quality of the feeding, the volume will slowly follow. But if we are only concerned about volume, the quality of the feeding is going to be lost, and then the volume will be lost too. And I share with parents that the baby's physiology literally may not support their ability to reach full oral feeds. And I try to put that out there pretty early to them. I don't want them to see that this baby not reaching full oral feeding is a failure upon the baby or upon them. It is just the way their body is set up. And I'll tell them, is it useful if the baby is taking everything by mouth but not gaining weight because they're working too hard? Because if that's the case, that NG is going to have to go back in. So treatment, look at the big picture. Based upon what you know about the defect, what might you expect? If it's an acyanotic defect, those kids might move along a little more quickly, a little more smoothly. The cyanotic defects, 90% of the time, are going to have a much harder time meeting their developmental milestones or meeting full oral feeds. So I try to use strategies first, diet modifications only when needed. Typically, the only kids on our unit who have to have a diet modification are the babies with a paralyzed vocal cord. So some things that my go-to things out of my bag of tricks is adjust the flow rate, adjust the nipple. I've had some babies have to go on the ultra preemie. They won't take a lot by mouth, but they'll do so safely. Don't fill the nipple fully. Slower is always better for this population. Positioning, so we do a lot of elevated swaddled sideline. Pacing, so we know that that can help with endurance if we're helping them, showing them, giving them those breaks when they need it. Limit feeding times. I don't like to tell a baby or a family or a physician, let's do every other feeding, because what happens when that baby is wide awake and queuing at that in-between feed when they're not technically allowed to feed. So what I'll often recommend is PO feeds twice a day or 3 times a day per the baby's interest. So that way we can respond to their cues. And then teaching caregivers how to recognize and respond to feeding cues. What does interested look like? And more importantly, what does all done look like in their baby? Knowing that we can't push this stressed and exhausted baby because that is not a successful feed. And I think it's really important to help them redefine what a successful feeding looks like. If that baby is taking 5 mLs well and then is telling us that he or she is done, it's important to respect that. I don't want to push them to take 30 mLs when they're telling me no, no, no. What happens in the neonatal period is that we are laying down the groundwork for a lifetime of feeding and eating. So for babies with vocal cord dysfunction, we do a lot of side lying. So I hold them with their right side down so that gravity will assist that left cord, when the left cord is the one paralyzed, will help the left cord with closure. I have read that you can position the baby upright with the head turned to the weaker side, but I have not had any success with that because I don't have 3 arms to do all of that. Positioning, elevated side lying can help reduce tachypnea and work of breathing. Many babies with CHD tend to have faster respiratory rates at baseline. So it's important to look at the quality of the breathing and not just the rate. For example, in our NICU, they often won't feed a baby who is breathing over 60. If I have a baby who's breathing at 60 but is looking quite comfortable, I might do some small volume with them to make sure that they are able to develop some skills. In babies with known aspiration, particularly the single ventricle babies, I'm hesitant to increase the volume of thickened PO feed because of the risk of neck and the risk of aspiration with fatigue. So in these babies, what we've done on our unit that worked fairly well so far is we'll do small volume, sometimes it's 15 mLs or less, small volume twice a day or so of a thick feed, and then they're getting the rest unthickened via tube. And it's a nice happy medium where that baby's getting all the nutrition they need, they're developing skills, and we're reducing their risk of necrotizing enterocolitis. For the baby who fatigues quickly, I've used the Dr. Brown specialty feeder with some success. I've found it most useful for babies who haven't had surgery yet and they're just needing to grow to get to surgery. And I've had 1 to 2 where it's actually helped to avoid a feeding tube. So that has been, the parents have been incredibly excited about that. For those babies who don't feed orally, whether they have GI issues, aversion, they're just not able to eat by mouth, we offer a lot of taste in the form of a pacifier, assuming they'll take a pacifier, any plastic, rubber, easy to wash toys, spoons if they're old enough, hands, etc. I've told parents, I don't care what the quote-unquote utensil is that they take taste off of, as long as they are enjoying it. So breastfeeding in CHD, it's challenging, but it's not impossible. It does provide some sense of normalcy for moms who have probably felt pretty helpless during this entire process. A study by Barbas and Kelleher in 2004 looked at breastfeeding success. So some of the comments that they received included, I didn't feel that staff stressed the importance of breast milk. Everyone, including nurses and other staff, seemed to think that formula was best. I didn't want to harm my baby. Nurses need to learn to not act like breast milk is yucky, and lack of time and privacy for breastfeeding. So the fact that any mom thought that breast milk was harmful to her baby is painful for me to read as a therapist. And I can only imagine how she felt. So our job is to ask moms what their home plan is. Is their goal to exclusively breastfeed? Is it to do just bottle feeding? Is it to do both and promote whatever it is that they want to do? But I'm also really honest with these moms, and I'll tell them, if you just want to breastfeed, they may not be able to do that. So that the possibility for going home with a tube does exist. But despite that, we are there to advocate for what they want to do, and we're there to support that. So in our unit, we tend to get really fixed on volume, and it can be harder to measure volume with breastfeeding. But again, it's not impossible. You can do pre and post weights. So you just grab a baby scale, weigh the baby before feeding, let them feed, and weigh them again, and you can get a pretty accurate volume in that way. These are some of our guidelines we use in the hospital in regards to breastfeeding time. So if the baby feeds less than 5 minutes, we call this practice, skill building, or bonus. So in this case, they would get their full volume via NG. If they're actively nursing for 5 or 10 minutes, we'll say that's 50% of the volume. They'll get the other 50% via NG. If they are actively sucking, swallowing, nursing for 10 minutes or more, we consider that a full feed, and they wouldn't get anything via NG at that point. I wanted to talk very briefly about transplant because, like I said earlier, just because you have all of these surgeries does not mean that you're immune from transplant. And transplant itself is not necessarily a cure either. It's a really good, strong Band-Aid, but not a cure. So the evaluation process, these babies and children go through blood tests and blood typing so that the donors are compatible. Our babies or our kids get a lot of transfusions. So the more transfusions you have, the more antibodies you have, the harder you can be to match. They do labs to look at liver and kidney function. They'll do viral studies for antibodies that can increase the risk of rejection. They'll do a urinalysis, an EKG, some imaging, a cardiac catheterization, and a social work assessment. And that includes what supports does that family have, because this child's going to be on lifelong medications. It's a lifelong issue. So can the family handle that? And in transplant, there's a listing status. So 1A is the top of the list. So if you have a patient who's on 1A, they are typically on a vent or on ECMO, or they have a VAD, a ventricular assistive device. They may be less than 6 months old and the need for continuous prostaglandins. They need IV inotropies in a high dose or needs more than one of them. They're at risk for death in 14 days without transplant. 1B is the next level down on the list. They still need the inotropes, but in a lesser dose, but they're still dependent on IV meds. They are less than 6 months old, but not on a vent, ECMO, or VAD, but they're not growing at a certain rate. Next level down is status 2. So these are usually your older kids, but they are stable on oral meds and they get to wait at home. And then it goes from 2 to 7. Status 7 is these patients are inactive on the list due to a change in condition, but they don't lose the time that they have accrued already waiting. So status 7 patients could have complications from an illness. So if they get some kind of viral illness or pneumonia, or they had a stroke or some kind of other event that would make them not a good recipient right now, then they would be placed on 7 and then hopefully back up to whatever status they were on prior once that immediate situation is addressed. Typically, if your baby or child is relatively quote-unquote healthy pre-transplant and it's a relatively smooth course post-operatively, it's unlikely that you would see new feeding or swallowing issues. In a quote-unquote smooth transplant, the patient is usually extubated within 24, sometimes 48 hours. However, if that patient has complications either pre-transplant or sometimes there's a slew of complications post-transplant, know that you're starting kind of back at square one with your evaluation. One thing I would like to do on our unit, and we need to do more of, is to do a language or cognitive evaluation pre and post-transplant to see if there are changes. We don't do enough of it yet, but I'm hopeful to do more in the coming year. In conclusion, this population can be among the most fragile in the hospital. They and their families will spend weeks, often months at a time in the hospital. It's our job to help them do their best to reach their maximum potentials. They'll bring you to your highest highs and your lowest lows. I can tell you that I have cried happy tears, or nearly cried happy tears, when one of my babies did some spoon feeding for the first time while she was in the hospital. Mom is bawling. I'm doing everything I can to hold those happy tears inside. And I had a similar situation with a teenage boy who had a neurological insult and had been kind of neurologically storming for several days. I noticed a difference in him on this particular day, and I said, today's the day he's going to talk. And I looked at him and I said, say hi, Mom. His mom was there, and he did it, and you know, it was a room full of happy tears. But I've also hugged a mom who just lost her baby, and just holding her and telling her how much I loved her baby and how outstanding of a mom she is. So yeah, I've been at the highest high and at the lowest lows. But they will impact your life for the better the way they have mine. Thank you all for listening today. I appreciate your time and your willingness to learn something that I'm very passionate about.